You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about ICD therapies. We'll talk about VT and VF detection zones, anti-tachycardia pacing, device-initiated cardioversion, strategies for reducing inappropriate shocks, and other types of ICDs. Let's start with VT and VFib detection zones. VT zones are programmed to detect ventricular tachycardia, which usually refers to rapid, organized ventricular rhythms, rates between around 150 to 200 beats per minute. Most ICDs allow for programming of one or more VT zones, typically based on the rate of the tachycardia. The device will classify any rhythm within this zone as VT and initiate therapy such as anti-tachycardia pacing or a shock if ATP fails. Many ICDs allow for additional zones, such as a slow VT zone for detecting slower, potentially dangerous VTs. The VFib detection zone is programmed to detect very fast, disorganized ventricular rhythms, usually 200 to 220 beats per minute, where immediate defibrillation is necessary. Detection in this zone typically requires fewer intervals, a shorter NID, which I will explain shortly, compared to VT zones because the rhythm is often life threatening and needs urgent therapy. In the VFib zone, you usually skip ATP therapy and ask the device to immediately prepare to deliver a shock as the rhythm is unlikely to respond to pacing. The exception is in Medtronic devices. By default, they give ATP in preparation for the very first shock for VFib because in some rare cases that resolves the VFib. VV intervals or ventricular intervals refer to the timing between consecutive ventricular events, whether they are intrinsic beats or paced beats. If the VV interval is slower, meaning longer, than the slowest programmed and enabled tachyarrhythmia zone, then the rhythm will be considered a normal sinus rhythm. Events in that zone will be labeled normally as V-sense, ventricular sense, or VS. A consistent short VV interval typically suggests a regular tachycardia, such as monomorphic VTach, whereas variability in the VV interval suggests a polymorphic VT or VFib. If ventricular tachycardia occurs with a cycle length of 350 milliseconds, which corresponds to 171 beats per minute, this interval falls into what we would typically set as the program VT zone. The VT zone is the zone between the program VT detection interval, VTDI, and the program VF detection interval, VFDI. Events sensed in this zone are labeled as tachysense, TS. If ventricular fibrillation occurs with a sense interval of 280 milliseconds, that interval falls into what we would typically set as the program VFib zone, which is any interval shorter than the program VFDI but longer than 120 milliseconds. Events shorter than 120 milliseconds are considered non-physiologic by the device, as that corresponds to faster than 500 beats per minute, which is not physiologically possible and more likely to be artifact. Events sensed in this zone are labeled as fibrillation sense or FS. In most devices, you can program 2 to 3 therapy zones and 1 monitor zone. The VFib zone, for example, 320 milliseconds, that corresponds to 188 beats per minute. The fast VT zone, for example, 240 milliseconds, which corresponds to 250 beats per minute, and can be programmed in two ways: fast VT via VF or fast VT via VT. Then you have the regular VT zone, for example, 360 milliseconds, which corresponds to 167 beats per minute, and the VT monitor zone, which is a zone that stores slower VT episodes without delivering therapy. Events sensed in this VT monitor zone do not impact detection counters. When a certain number of intervals are sensed in a particular detection zone, an episode is detected and there will be a label, TD, which is VTach detected or redetected, and FD, which is VFib detected or redetected. Sometimes a monomorphic VTach that is fast enough to reach the VFib zone may be falsely labeled as FD for a VFib episode, fib detected. Sometimes undersensing may lead to a VF episode being incorrectly classified as a VT episode with the label TD for VTAC detected. What's the NID? I mentioned this at the start. NID is the number of intervals to detect NID before calling VT. For example, if NID is 16, then you need 16 intervals of TS VTAC sensing events before VT is considered to be detected. Note that any events occurring outside the program VT zone would reset the counter to 0, causing the VT counter to begin again. In contrast, VFib uses a probabilistic counter, meaning a fractional counter, since some of the signals are really small and a regular NID would be reset to 0 too many times to be effective. For example, NID would be expressed as 18 over 24, meaning 18 out of 24 consecutive intervals should be F-sense in order to detect a VFib. But for both VFib and VTAC's NIDs, you specify a redetect number, or a fraction in the case of VFib, that is lower because once an episode happens, you want to be more sensitive about detecting another episode again. A combined count is used when the rhythm fluctuates between VFib and VTAC zones. In the case of Medtronic, when the VFib counter reaches 6, it refers to the combined count of NID, which is 7 or /6 times the programmed VFib NID, rounded down to the nearest integer. When the sum of the VT and VF counters is equal or greater than the combined count NID, then detection is met. The device then reviews the last 8 intervals leading up to detection. If one of these 8 intervals falls into the VFib zone, then VFib is detected and it delivers VFib therapy. If all 8 intervals fall in a VT zone, then VT is detected and it delivers VT therapy. In Medtronic, this configuration is called NID for number of intervals in detect, but exists in the other devices as well. In Boston Scientific and Abbott St. Jude, this can be changed under detection intervals. In Biotronic, this can be changed under detection settings. You'll notice that in my pacemaker and ICD examples, I'm using Medtronic to illustrate important points. The only reason for this is because they comprise the largest percent of pacemakers and ICDs, both in the United States as well as internationally. So I'm trying to illustrate for you what you will see practically. I have no bias for or against this company, and I do not hold any opinions about the superiority of pacemakers and ICDs by Boston Scientific, Abbott, Biotronic, or Medtronic, nor do I hold any stock. These companies all have their own online educational portals, which you are welcome to check out on your own time. And I've also tried to give equivalent examples from each of these manufacturers whenever possible. So that's my little disclaimer. Now we can move on to anti-tachycardia pacing, or ATP. Fast pacing pulses using pacing level voltage rather than shock level voltage to interrupt the reentrant circuit of an arrhythmia in a pain-free manner is what we call anti-tachycardia pacing. In ventricular tachycardia, which is a reentrant arrhythmia, there is an excitable gap, an area of repolarized tissue which has not yet begun to repolarize again and is capable of stimulation. If ATP pulses are delivered to depolarize the excitable gap before the new wave front arrives, the new wave front will be blocked and the reentrant tachyarrhythmia is stopped. That's why ATP can be successful. When ATP is delivered, the rate it is delivered at is a pacing interval that is a set percent, usually around 90%, of the average RR of the last 4 detected tachycardia beats, the TSs. For example, if the last 4 tachycardia beats had an average RR interval of 300 milliseconds and you had set the adaptive percent to be 91%, then your atrial tachycardia pacing will be delivered at 270 millisecond pacing intervals. Remember that a lower adaptive percent means a faster pacing rate. You also set a VV minimum ATP interval, for example, 200 milliseconds, and you set the number of pacing stimuli pulses you want to deliver. If the first pacing train does not terminate the tachycardia and redetection occurs, a second sequence of ATP pulses is delivered, and so on until ATP therapies are exhausted or the arrhythmia terminates. With each sequence, an interval decrement, for example 10 milliseconds, that you pre-specify is applied so that the pacing intervals become faster. The first time, the pacing interval will just be the average of the last 4 RR intervals times the adaptive percent, for example 91%. The second time, the pacing interval will be the average of the last 4 RR intervals times the adaptive percent minus an interval decrement, for example 10 milliseconds. The third time, the pacing interval will be the average of the last 4 RR intervals times the adaptive percent minus 2 times that incremental decrement, so minus 20 milliseconds instead of minus 10 milliseconds. Burst, ramp, and ramp plus are 3 types of ATP. A burst is pacing stimuli delivered at equal intervals. A ramp is pacing stimuli delivered at progressively shorter intervals by multiplying the adaptive percent. For example, if the adaptive percent is 91% and your initial number of pulses is 4 and your last 4 RR average is 350 milliseconds, then your first sequence will deliver 4 pulses with the following intervals: 320 milliseconds, 310 milliseconds, 300 milliseconds, and 290 milliseconds. Each subsequent pacing also adds one more pacing pulse. If burst and ramp attempts do not work for VT, then the device can deliver a shock at 35 joules. ATP is successful 72% of the time, and ATP is often delivered without the patient's knowledge. Now let's move on to device-initiated cardioversion defibrillation. Cardioversion is delivered for VT and fast VT episodes. It is always synchronized and delivered on the R wave. You specify the energy, for example 20 joules or 35 joules, and a pathway for each cardioversion. You're not allowed to decrease the number of joules with successive cardioversions. It has to be the same number or higher. Defibrillation is delivered for VFib, which is unorganized and a result of many reentrant circuits. The ICD will attempt to synchronize the shock to an R wave first, but will deliver the shock regardless of whether the synchronization is successful. You specify the energy, for example 35 joules, and a pathway for each shock. You can either just specify the number of joules to be the maximum, or you can program it to be an optimized value, such as the defibrillation threshold plus 10 joules, which can terminate a VFib with an appropriate safety margin without wasting energy. If the ATP during charging or ATP before charging feature is on, a minimum of 20 joules is recommended for the first therapy, because if you choose a number of joules lower than that, the charge will occur so fast that there is no time for the ATP to be delivered. High voltage coils can be single or dual. A single coil is placed in the RV. If dual coil, one is placed in the SVC and the other is placed in the RV. You will want the shock to encompass as much of the heart's muscle mass as possible. There are 3 vectors available, where B is the right ventricular coil, X is the superior vena cava coil, and A is the can. B to AX covers the largest area. So that's going from the RV coil to both the can and the SVC coil. B to X excludes the can. B to A excludes the SVC coil. You can also reverse the direction of any of the above. While charging, before the ICD delivers the first fibrillation shock for a VFib episode, it monitors the rhythm to confirm that VFib remains present at the end of the charging. When 4 of the last 5 events is normal, meaning the interval is longer than a confirmation interval, then the ICD stops charging and aborts the planned shock because it assumes the patient is no longer in VFib. During confirmation, the ICD will look at the last 6 VV intervals leading up to detection. If the difference between the shortest and longest of the last 6 VV intervals is longer than 50 milliseconds, the rhythm is considered polymorphic. The calculated confirmation interval for a polymorphic rhythm is 60 milliseconds longer than a VFib detection interval, the VFDI I mentioned earlier. If the difference between the shortest and longest of the 6 VV intervals is shorter than 50 milliseconds, the rhythm is considered monomorphic. The calculated confirmation interval for a monomorphic rhythm is 60 milliseconds longer than the detected arrhythmia cycle length, but must be at least as long as the programmed VFDI. ATP before and during charging. ATP during charging provides a chance for ATP to break the arrhythmia without delaying the shock. ATP before charging may conserve battery longevity because if the ATP before charging is successful, the device may not need to charge for the defibrillation shock anymore. In Medtronic, while in ATP before charging mode, if there are two ATP before charging failures, it will switch to ATP during charging. While in ATP during charging mode, if there is one ATP during charging success, it will switch to ATP before charging mode. Equivalent features to ATP before charging and ATP during charging exist from each manufacturer. In Boston Scientific, it's called RV-ATP or ramp therapy. In Abbott, it's called ATP on-off. In Biotronic, it's called ATP one-shot. We should also know strategies for reducing inappropriate shocks. Inappropriate shocks occur in 20 to 30% of patients over the lifetime of the ICD. 35% of shocks are inappropriate, for example, for SVT, which is the most common cause, NSVT, lead fracture artifact, T wave oversensing artifact, or electromagnetic interference, whereas 65% of shocks are appropriate, for example, for VTAC, VFib. In terms of reducing the inappropriate shocks, think about the detection criteria. For example, the number of intervals to detect. You can set the VFib detection to 30 out of 40 instead of the standard 18 out of 24 in order to reduce the chances of misclassifying non-sustained ventricular tachycardia. Then you can also look at the anti-tachycardia pacing, ATP before charging. Using ATP during charge up for VTIC, VFib can reduce unnecessary shocks. ATP in fast VT, this can terminate fast VT in 75% of cases, reducing shocks. Then also think about your discrimination algorithms. You can turn on algorithms for SVT VT discrimination based on morphology or rate, which helps distinguish SVT from true VT. And then you can make sensitivity adjustments. You can fine tune to reduce T wave oversensing or lead fracture artifact. Finally, you can educate patients and providers about magnet use to temporarily disable shocks in a case of recurrent inappropriate shocks due to artifact or external interference. We'll close out this episode by talking about other types of ICDs. There are also subcutaneous ICDs and wearable ICDs, such as the Life Vest. According to the 2017 Sudden Cardiac Death Guidelines, in patients who meet criteria for an ICD who have inadequate vascular access or are at high risk for infection, in whom pacing for bradycardia or VT termination or as part of CRT is neither needed nor anticipated, a subcutaneous implantable cardioverter defibrillator is recommended. That's a Class 1 recommendation. In patients who meet an indication for ICD, implantation of a subcutaneous implantable cardioverter defibrillator is reasonable if pacing for a bradycardia or VT termination or as part of CRT is neither needed nor anticipated. That's a Class 2A recommendation. In patients with an indication for bradycardia pacing or CRT, or for whom anti-tachycardia pacing for VT termination is required, then a subcutaneous implantable cardiac defibrillator should not be implanted. Class 3. What about Life Vest? According to 2017 Sudden Cardiac Death Guidelines, in patients with an ICD and a history of sudden cardiac arrest or sustained ventricular arrhythmia in whom removal of the ICD is required, as in with infection, the wearable cardioverter defibrillator is reasonable for prevention of sudden cardiac death. That's a Class 2A recommendation. In patients at an increased risk of sudden cardiac death but who are not ineligible for ICD, such as awaiting cardiac transplant, having EF of 35% or less, and are within 40 days from an MI, or have new diagnosed non-ischemic cardiomyopathy, revascularization within 90 days, myocarditis, or secondary cardiomyopathy, or a systemic infection, then the wearable cardioverter defibrillator may be reasonable with a Class 2B recommendation. So that's all I have for you for ICD therapies. We talked about VTAC and VFib detection zones, anti-tachycardia pacing, device-initiated cardioversion and defibrillation, strategies for reducing inappropriate shocks, as well as other types of ICDs.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.